Welcome or welcome back. I'm Mike Berry, President of the Informed Medical Decisions Foundation, and welcome to day 2 of our meeting, Aligning Incentives for Patient and, in fact, Family Engagement, Enabling Widespread Implementation of Shared Decision-Making. I know we have a few people who've joined us this morning, and just to recap a little bit, we spent yesterday hearing from some real experts in patient and family engagement, starting with Angela Coulter, Christine Bechtel from the National Partnership, and Dominic Frosch as well, bringing the perspective of the Gordon and Betty Moore Foundation, who again are co-sponsors of the meeting, and we appreciate their generous support and thoughtful participation in both planning the meeting and what we'll do to follow up on the meeting. We also heard from our demonstration sites practices working to integrate patient and family engagement in general and shared decision-making in particular into day-to-day care. We heard about challenges and stories of how to overcome that. We heard from our patient representatives from those sites of how important it is that we do so. And today, we're going to move on to focusing again on aligning incentives because, again, if we could do all this with incentives misaligned in some places, what can we do when they're aligned? How can we bring it to scale? And I think as I'm thinking about this, I'm thinking more broadly than just aligning incentives, but what are the levers to spread shared decision-making farther and faster over time? And again, we got lots of great ideas yesterday. We're going to focus, particularly in our second session today, on getting more of those on the table, and I'll come back to that at midday when it's time for us to go, talking about the post-meeting plans. But it's my pleasure to kick off the morning with our second plenary address with an old friend, Jack Wennberg. And, you know, people say people need no introduction. It's really true for Jack. Jack was an inspiration to me as I started my career, coming out of training thinking all doctors did things the same wherever they lived. Moving from Rochester, New York, where costs were relatively low, to Boston, where costs were relatively high, was eye-opening for me, and Jack could show me maps of these interesting places where 10% or 50% of men would get their prostates taken out by the time they're 80. I thought there was something in the ponds and streams maybe accelerating or retarding prostate growth, but the secret was behind the closed doors of clinicians' offices rather than in the water. So Jack is the Peggy Thompson Professor Emeritus in the Evaluative Clinical Sciences and founder and Director of Emeritus of the Dartmouth Institute for Health Policy and Practice. He has been a professor in the Department of Community and Family Medicine since 1980 and the Department of Medicine since 1989. Jack and his colleague, Dr. Al Mully, another mentor of mine, are co-founders 24 years ago of the Informed Medical Decisions Foundation. Jack is also the founding editor of the Dartmouth Atlas of Healthcare that so many of you are familiar with. As we say at the foundation, somewhat biblically, in the beginning, there was practice variation, and it's still here. So the Atlas Project has also reported on patterns of end-of-life care, inequities in the Medicare reimbursement, and underuse of preventive care. Jack, in addition to being a founder, is an ongoing consultant for the Informed Medical Decisions Foundation, receives royalties from Health Dialogue, and is the author of Tracking Medicine, which you have in your packets today, just a remarkable resource describing the problem of practice variation and potential solutions over time. So with that, I'll introduce Jack to kick off the morning. Thank you.
You can see that I was the first to introduce Mike to the prostate, which has kept him going for a long time. See if I can get this to work. Yeah, there we go. Mike actually asked me to give an overview of practice variations, particularly in the context of this meeting, about how we can address them. The story really in a nutshell, is that a medical practice occurs within a local context. Per capita expenditures, resource use, and utilization vary extensively among regions, communities, and healthcare organizations. And much of this variation is unwarranted. It can't be explained by evidence, illness, evidence-based medicine, or patient preferences. And the causes and remedies of unwarranted variation differ according to the category of care. And this, in this category of care concept was something which I began to see as a simplifying kind of model for categorizing variation. These are fuzzy sets, there's overlap, but it's easy to see that there is an effective care category, that is to say, services for which there is consensus that a particular treatment works, and for which there's evidence that it works, and for which there's not a lot of options. And the case here would be the classic idea that as part of the contract the patients make with the healthcare system to take care for them, they could expect to get those kinds of services when they need them. And so our issues of patient preferences and supply-sensitive care, which are the other categories I'll be talking about, really don't enter into this. And here the problem, quite frankly, has been underuse. We have documented a number of examples of underuse of effective care. The good news is that once you document it and once somebody makes it an issue, you actually can fix it. So we started out with such things as variation in the use of beta blockers after heart attack, which were quite extraordinary. But by the time CMS and others ganged up on the system and began to publish it, everybody gets their beta blocker, which is good news. The unfortunate thing is, first of all, this category is somewhat empty. There aren't that many things that fit neatly into it without controversy. And secondly, it doesn't account for very much of the spending in healthcare. You have to add such things as hospitalizations for hip fractures or hospitalizations for strokes to this bucket in order to get about 10 or 12, 15% the most of spending being explained by the members of that category. So it is the preference side, the preference-sensitive category, and the supply-sensitive category, which are the important ones from the point of view of costs, and also from the point of view of the patient experience, as we're talking about it here in terms of the imposition of constraints on patient active engagement in the decision process. So I'd like to spend my time working through the categories of preference-sensitive care and supply-sensitive care, each of which involve different aspects of this problem of unwarranted variation. Now, the preference-sensitive care category is one that's, I'm sure, familiar to everyone in this room because that's what you are working in. But it's basically these kinds of decisions involve trade-offs. There's more than one treatment that exists, and the outcomes differ. The decision should be based on the patient's preferences, on the ethic of informed patient choice. And you'll notice I'm trying to ground this assertion here, of normative assertion, in ethics, not costs. But provider opinion often determines which treatment is used. In Al's terms, the misdiagnosis of preferences would be what we're talking about here. Now, in looking to the story, I always like to start, as Mike has said, with Boston, in this case not Rochester, but New Haven, which is the fairchild of this. And I like to use these two communities, even though most of the work that was behind my understanding of practice variations occurred in northern New England in the early days. It wasn't until we cracked the Boston-New Haven nut that anybody even paid any attention to this, because, after all, Vermont's out in the hinterlands, and what goes on there might as well be in Quebec. So we really didn't we didn't get much traction. But when we look at Boston-New Haven, let's look at the pattern of practice for surgical procedures. And here we're looking at the relative rate in Boston and New Haven for inguinal hernia. And it turns out the rates were identical. And hernia is one of those few conditions which, in the old days at least, used to be effective care measure. Everybody who had an inguinal hernia, it was assumed, was at risk for strangulation. And the theory of surgery said operate early to prevent something bad happen in the long run, which is strangulation and other kinds of nasty things. So therefore, if you have a hernia, operate. And indeed, the market was more or less cleared of hernias, at least indirectly, by looking at the pattern of variation, which we saw very little of. Now, it turns out 25 years later, a randomized trial was done about hernias, and it was found that with, I think, some 1,200 or maybe even more patients on each side, that they simply didn't find any strangulation. So strangulation turned out to be a much less important event. And in fact, the paper basically came out to say this should be viewed as a preference-based decision depending on whether or not the patient's bothered by the symptoms, which gets us back to this whole quality of life issue. So, but when you look at other procedures, Boston excelled in carotid endarterectomies. This is the ratio to 2.3 times higher rates. Remember, these are all rates in the region, so this is the risk if you live in, the relative risk if you live in Boston compared to New Haven. Knee replacements and hip replacements, much higher in Boston than in New Haven. But on the other hand, coronary bypass was much lower, hysterectomies in the middle, and back surgery 30% lower than Boston, New Haven. This is the typical surgical signature that we describe in the book and lots of things we've done. And the surgical signature basically is consistent over time. It's not just a snapshot. So it is called the surgical signature because if you look at the profile, you can actually say, oh, this is Boston, without knowing it's Boston, basically, at least but not being told it's Boston. Now, the atlas allows us, the atlas came on the scene a good deal later than the Boston-New Haven pics, but it allowed us to look across the country at the variation which we had been previously seeing, albeit only for the Medicare population. What we looked at was a number of surgical procedures, and surely enough, the communities would differ in the same characteristic way. We also were able to develop some pretty interesting longitudinal stuff now that we could follow communities over and over. Now, this is the rate of knee replacement. Remember, this was one about 60% higher in New Haven, or in Boston than in New Haven. And you see, over a period of time, the rates are increasing from 4 per thousand in 1992 to almost 9 in 2007. But the variation certainly doesn't seem like it's going down. In fact, if you measure it precisely, it's pretty much the same. The scale here on this graph will make it look like the latter year is a little bit more variable, but it really isn't. It's just about the same. But what's even more interesting, I think, is that there's no regression to the mean. In other words, you might look at those data, and doctors did, thinking that, well, if we just wait a couple of years, it'll all even out. When in fact, geography in this case is destiny. The rates that existed in 1992 highly predict the same risk in the year 2007, or to be quite honest, or quite precise, they predict the risk today in these communities. And underneath this, of course, is an economy in which the physicians are able to find enough work in all regions to essentially increase the rates without ethical qualms. And it's interesting that some of our most progressive and interesting places are at the top end of this. For example, the Mayo Clinic, for example, Intermountain Healthcare. So it isn't as if it was all self-evident Miami, it must be something bad. No, this is a real problem of what's going on. Now, the basic issue here, I think, is best illustrated by a paper that was done by Julian Hawker and colleagues, in which they set out to actually determine the need for knee and hip replacement based on a very simple algorithm. It was based on symptom score, the WOMAC score, and the presence of an X-ray that said, yeah, there's a lesion in here that could be fixed by surgery. And they did a random sample, basically, and were able to administer the severity score, then took the X-ray and said, well, wow, this seems to be more people around here that need it than are actually getting it. But then they did the next step. They basically administered a decision aid and then asked the question, the conditional probability of wanting to have it after you've been defined as being clinically appropriate. And it turned out that only 15% of the patients that were clinically appropriate by the definition of medical necessity, or I mean medical evidence, actually wanted to have the procedure at that point in time. We learned yesterday that if you wait 2 years, maybe they'll change their mind. But the point was here that determining need required essentially an understanding of patient preferences. In other words, we could sort of make a little diagram saying that medical necessity equals clinical appropriateness or evidence-based medicine plus informed patient choice. And this is the underlying phenomenon that allows the market basically to be so irrational, is that informed patient choice aspect of this is simply not in place. And that is what the big job of this organization and all of you is all about. But to be realistic, you are facing extraordinary economic pressures because of this. Namely, in each of these regions, there is a thriving business that is targeting to do so many procedures a year, in the sense that that's what's required to keep both the system working. And now we're going to intervene with shared decision making. And we see successes, certainly, but the economic incentive problem needs to be really addressed and understood. Now, the good news is that we do know that informed patient choice as an ethical imperative does uncover true demand. So now we can begin to talk about which rate is right in the context of some pretty solid information that would be respected by our economist friends, for example. And the ones at Dartmouth are all converted to this concept, so it's possible to get economists interested in this dilemma. But in the absence of informed choice, surgeons are at risk of operating on the wrong patient, misdiagnosing preferences is another way of looking at it, and operating on the wrong patient looks like more of a problem in battery and legal issues, which I think are going to be working out over the next few years. Ben will correct me on that, because he's leading this to a large extent. But by moving towards the concept that informed choice is the way that one activates informed informed consent, we have another lever, I think, for moving the field forward in ways that may be equal to the pressures to the economic pressures that are here. Effective tools are available, as we've talked about, and of course we do have this one example now, and I think that David Otterburn will be talking about it later, of actually now having a defined population, namely the people that are using group health. We now are in a position to actually understand what the demand is under this shared decision-making model, and with follow-up of patients over time to look at crossovers and looking at new patient intakes, we have the beginnings of a dynamic system for addressing this normative question about the right rate. Now, Michael asked me to spend some time on the supply-sensitive care problem. And just to give you a sense of where I'm going on this, is that supply-sensitive care collides with preference-sensitive care around the topic of end-of-life care, where it's clear to everyone in this room that there is a major component of preference-sensitive decision-making is around end-of-life care. But I want to illustrate the complexity of that particular phenomenon or that particular aspect of utilization because it rests at the heart of the supplier-induced demand problem. So let me just go back, I'm sorry. That when I talk about supply-sensitive care, it's basically everyday services provided to patients with medical, not surgical conditions, like a physician visit, referrals to specialists, MRIs, lab tests, screening exams, and hospitalizations and stays in intensive care unit are examples. At issue is the frequency of the use of such care, particularly in managing chronic illness, and that's where the which rate is right question emerges. But supply-sensitive care accounts for most of the twofold variation in Medicare spending among regions. That's another thing which is really important to keep in mind when we're talking about Miami and other places that are really high, or Seattle that's really low, or Minneapolis that's really low. It is the intensity with which chronically ill patients are treated that is the determinant of the variation in spending. Now again, Boston, New Haven. What we knew from many years' work was that Boston had many more beds invested, or put it this way, that the hospitals serving Boston, in terms of their capacity, delivered 55% more patient days to the people living in Boston, had more employees, and almost double spending per capita for their hospitalizations. And when we looked at the variation, what we were seeing was not the surgical signature phenomenon, but rather an across-the-board higher utilization threshold for utilization across all kinds of chronic conditions. You can read them on the bottom here, but the ratio up the top is the ratio of Boston to New Haven. So they were, in all of these examples, COPD, cancers, congestive heart failures, et cetera, the hospitalization rates in New Haven were less or lower and higher in Boston. This was our first sort of, well, not the first, but a really good illustration that capacity influences across the board the threshold for admitting chronically ill patients. Now, one of the things that I did at this point in time was to go actually down to New Haven and Boston with that slide, equivalent slide, but without identifying who was who. And I was interested to find out, is there awareness on the part of the clinicians who are actually doing the admitting rates or taking care of the patients in the hospital? Were they aware that they were different? And the answer is no. They did not know. Bostonians thought they were more efficient than New Haven on the basis of history or whatever. And physicians who practice in both communities were not able to distinguish a change in what they were experiencing. Now, this is all anecdotal and it's interesting, but to me it was a real eye-opener about the subliminal effect that capacity exercises. This now will give you a more systematic example of this problem. So here, this is from the atlas, and each one of these dots is one of the 306 regions that we look at. And I think you can clearly see that for the green dots, which are all medical admissions, there's a pretty darn strong relationship between acute care bed capacity, which is the horizontal axis, and the admission rates. By contrast, for hip fractures, which is the one condition for which we can say with some certainty that if you get it, you get in the hospital. Therefore, hospitalizations is a measure of incidence. There's virtually no relationship between capacity and utilization. Similarly, for visits, cardiologists per capita on the horizontal and visits to cardiologists on the vertical. Now, this is not surprising. It really shouldn't be. But what the mechanism is here, that as you increase the supply of cardiologists, you decrease the interval between revisits for patients that are in their cohort, chronically ill patients with congestive heart failure generally. And again, this is a subliminal issue. Doctors don't even have a debate about what's the right interval for revisiting somebody. It's never discussed in medical grand rounds. It's one of those things that just isn't recognized, and yet it's fundamental driver of our utilization patterns. So the frequency of use then is governed by the assumption, and this is our behavioral interpretation, that more is better. If you have an empty bed and you have a sick patient, you should put them in. If you have an empty office visit and you have a sick patient or even a not so sick patient, you should fill it. That's what I mean by that. Specific medical theories and medical evidence play little role in governing the frequency of use. In other words, for surgical procedures, for supply sensitive, you'll never meet a surgeon who didn't know why he was operating. He may be wrong in the terms of the theory, and he may be wrong in terms of the evidence, but he knows why he's doing it. In this case, we don't even know why this behavior that I'm talking about here is subliminal. And it is impossible, at least I'd like to challenge you, to find any really systematic discussion in the medical literature about the theories and evidence about frequency of use. And this sort of nails it as far as I'm concerned. This shows you recent data, visits to physicians in the last 6 months of life from patients who have received most of their care from these academic medical centers. And I think you'll notice with some pleasure that all of this is involving Los Angeles and other places that are a long ways away from our audience today. But look, for example, at the differences between University of California in San Francisco. Oops, I knew I was going to do that. Oops, I'm sorry. I need a bigger button. Basically, and UCLA, so that visit rates to UCSF is about 28 per person in the last 6 months of life, and it's 49 or 50 there. And so you see huge variation. And it's quite clear from this, and I use this slide to emphasize that there is no consensus among our major academic medical centers in how to practice medicine with regard to care intensity, and not only in the last 6 months of life, but virtually the whole time frame in which these chronically ill patients are being cared for. One of the most important, I think, take-home messages that I do deal with in the book is that it's not end-of-life care that varies independently. It's the variation in every period of time prior to end of life. 5 years earlier still shows that Boston will be using more than New Haven, et cetera, et cetera. So this threshold effect affects the entire industry. And in the absence of evidence and under the assumption that more is better, available supply governs frequency of use. This is kind of the behavioral interpretation. Now, I'll go through very quickly that we basically have found no evidence that more is better in the sense of people living longer in places that have higher intensity of care versus lower intensity of care. We find that technical quality tends to be better in the low-use regions, stuff like beta blockers and so forth, once we were able to measure that. Patients rank the hospital experience higher in low-use regions. This is the HCUP studies, which we've looked at in terms of the variation at the hospital level as well as the regional level. Care coordination is better in the low-use regions. Fewer doctors get involved in the care of these patients, fewer referrals, and finally, end-of-life care is less aggressive in the low-use regions. And this is the point I kind of want to end with. Here is the probability, if you wish, but it's the percent of patients who are being managed at these different academic medical centers who died in association with admission to ICU, high-tech death, if you wish. You'll see that 40% of patients in UCLA and Cedars are in this category. At the bottom of the list, Scott and White, New York Presbyterian Hospital, and the Mayo Clinic are 15% up to 40%. So this is essentially a snapshot of the patient's experience of end-of-life care. And this is the environment in which you're going to be trying to intervene in. Now, the atlas will give you this information, so you can know what these probabilities are. But remember, first of all, that this behavior represents a snapshot at one point in time that reflects the entire behavior of the organization. So distinguishing between the end-of-life care and care that was two years earlier, you'll still see this variation. You won't see variation in end-of-life experience, but it's all leading up to this. And what this really says is that at the level of change, or in the dynamic of change, we've got to deal both with capacity, which represents mortgages, represents money flow through institutions, represents jobs, and we have to deal with a microsystem of informing patients about their options. And unless we're able to deal with both in some uniformed way or in some effective way, we are simply going to be jostling up against the economic incentives which are so much driving this. Because remember, it's jobs and it's mortgages, it's bond markets, it's all the kinds of things that are associated in many ways with our fragile economy right now. And the more we can draw attention to these problems, the more we can begin to get a broader constituency for change. And in this case, I think until we have the financial markets and the raters of bonds understanding that this is not a gravy train that's going to go on forever, we're going to continually have easy access to capital to build more institutions, upgrade them, change their configurations, which generally now means more intensive beds, more ICUs. So we have to think broadly about strategies and about opportunities. Now, Michael, I've taken a little time than I should have, but did I do what you wanted me to do? I didn't talk about the prostate, which is a one-time accomplishment.
We've had enough of that. But if there's a question or two for Jack, or reflections on Jack's way of looking at the world and what we need to be doing in patient engagement, we could take that. Please step up to the microphone.
Thank you very much, Jerry Fenster with American Medical Group Association. If you look at those groups at the bottom there, let's take Mayo, Scott and White, maybe Intermountain, Kaiser, that have a long history of developing their culture. And the question is many of our groups are now trying to move from fee-for-service to fee-for-value. How are they going to do this in a way that doesn't take 20, 30 years, is my question. How are they going to change their culture to the new way maybe of doing things?
That I would say is one of the microsystem problems. It's kind of the summary statement of it. And I would say that one does that by making sure that the Mayo Clinic sends one of its members to each of these hospitals and gives them some authority to persuade. That's all they can have. But I think that this is, of course, a tremendously important question that's not just for the supply sensitive, but also for the preference sensitive, is how do we change culture? I've tried to suggest, maybe sort of slightly indirectly, that if the financial markets get a wind of the fact that more isn't better, and insurers are going to be doing something about it, namely limiting growth in high-cost regions, then a lot of the capacity problem will begin to take care of itself, I think. It still means we've got to go to the difficult problem of trying to change the culture of doctors. But if they don't have the ICU beds, then their admission rates are going to drop. So that's pretty clear. So the question could even involve such arcane ideas as planning, but that'll take another cultural change at someplace else, like in Washington, D.C.
All right, so Jack, that actually is my question, because we've just been looking at healthcare costs in Indiana for a very large purchaser compared to Michigan. And Indiana is a state with no certificate of need, has extremely high health care costs for this purchaser and I think for many, compared to Michigan, which has certificate of need. But we've had a hard time with the policymakers understanding this, and I'm just wondering whether you've had any more success on that.
Yeah, you know, the thing that was, I had to go way back to the original paper that Alan Gittleson and I did in Science,
Yeah.
in which we showed that at that point health planning existed, and it was really, everybody was into it. But the planners were using institution-level data, occupancy rate mainly, to define need. And we could show very clearly that the population-based measures of bed inputs, like I just showed you briefly for Boston and New Haven, were uncorrelated with occupancy rate. So they were using the wrong measures, and they were basically saying hospitals that are in high-cost areas need more beds because they're pushing their occupancy rate up. So part of it is a measurement problem, and part of it's an understanding of the epidemiology of healthcare. The other is the will to regulate, which in Michigan you've got the will, but now you don't have the methods.
Okay.
You know, Jack, the last time I looked at the atlas, it looks like the difference between Boston and New Haven has gone away. And if that observation is correct, how did that come about?
That's an embarrassing question. There have been some slight anomalies in the data lately, and that's one of them. I don't know the answer to that, but I do know that it was associated with a very rapid growth of network IP of a network managed care program in the area. Part of it could be explained by that. We didn't see any difference in capacity dropping or increasing. So there are some phenomena going on with cost shifting and people preferring one stream of patients now that they didn't in the old days. So the stuff that we looked at, generally speaking, we haven't seen a great departure from this capacity issue. And besides, it's simple to check on it because you know they publish how many beds they're using, and so that wasn't it. So it was some shifting within different patient pools, but we didn't have the data to figure it out. But good question, Bob.
Peter, last question.
Good morning, Jack. Peter Goldbach, Health Dialogue. First, disclaimer, I trained at Cedars-Sinai, so kind of
we need a
guilt by association. Question about the culture of demand for services. Is there any evidence that patient demand, expectation of care based upon your family's experience and your friends' experience might drive some of this behavior?
I think that the behavior may well be the same in all places. The problem is that patients don't really sit up and demand hospitalizations for a chronic illness. And so they accept the advice of the doctor that that's the thing to do. So in the preference-sensitive area, I would be much more interested in building the capacity of consumers to change this. And in fact, that's what most of our argument is about.
Right.
But for the supply-sensitive, I don't think we can change it by directly trying to make patients better shoppers for end-of-life care. Although we might, because if there was a movement in Los Angeles that suddenly said, we've had enough of this aggressive end-of-life care, we have measures of the different hospitals in Los Angeles, and some of them are more conservative than others. So by moving patients from a high to a low-intensity hospital within Los Angeles, we'll have two problems. First of all, it will be good for them because they will begin to realize that lower risk of being in there. The remaining patients in the hospital, which they've abandoned, however, will probably absorb, the brunt of the loss of attributable population. So you have to begin to sort of think about this in terms of balloons that you can squeeze here and they'll pop out there. At least that's my thinking.
Thank you.
Join me in thanking Jack for his presentation today and his leadership in healthcare.